Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. It's Lindsay Smith-Rogers. Today, a look at preventing ovarian cancer, which can be difficult to diagnose and treat. Stephanie Desmon talks to Dr. Rebecca Stone, the director of Gynecologic Oncology at Johns Hopkins, about changes in how we understand ovarian cancer, that much of what is called ovarian cancer may actually start in the fallopian tubes, and about an underused surgery that preserves ovaries and may save lives. Let's listen. Rebecca Stone, thanks so much for joining me.
Thank you so much for having me. It's a real pleasure.
So today I want to talk about something with a difficult name to say, but it actually could save a lot of people's lives. So we're talking about salpingectomy, which is the removal of the fallopian tubes. And I understand that this could really be a game changer in ovarian cancer. Could you talk to me a little bit let's start with ovarian cancer, right? It's hard to screen for and it's deadly, and this can reduce the risk. Tell me, please.
I think sometimes when I talk to people about this, the first thing they're thinking is, well, okay, you're talking to me about ovarian cancer, and then you're talking about a structure that's not the ovary. You're talking about the fallopian tube. And so how do you make sense of those two things? And this is the fact that we're talking about the fallopian tube is related to a relatively recent scientific discovery that a large number of ovarian cancers, or types of cancer that we have historically called ovarian cancer, actually originate either directly or indirectly from the fallopian tube. And, many people have not thought about gynecologic anatomy or function ever, or maybe it was many, many years ago, but you may remember the fallopian tube is this small, thin structure that arises from the top of the uterus or the womb and sits immediately adjacent to the ovary. And so when the ovary produces an egg, the fallopian tube grabs that egg, and the egg goes into the tube, and then maybe if it meets a sperm there, there's fertilization event, and then pregnancy can happen. And so you can imagine that when a cancer starts in either the fallopian tube or ovary, it sometimes might be hard to discern, which was truly the primary site of the cancer, because we always say they're frenemies, or they live so, closely next to each other. And so, in medicine historically, there has been a group of cancers that we have called ovarian cancer. And I tell people, maybe it helps to think about the ovary sort of like a grape. And you might think a grape sort of has three layers. It has the skin of the grape, the fruit of the grape, and then the seed, like the germinal center. And traditionally, ovarian cancers have been attributed to one of those three layers, with the highest prevalence or most common types arising from what people thought to be from the skin of the grape. And that maybe is like 90% of ovarian cancers historically were attributed to the skin of the grape, and only about 10% to the fruit or the seed, the germinal center. But as people have really studied ovarian cancer and looked at, what do the cells look like under the microscope? And we've started to learn more particularly about people and families that have this hereditary risk of ovarian cancer. We really have come to accept that many of the cancers that we thought arose from the skin of the grape, the surface of the ovary, actually appear to come from the end of the fallopian tube that sits right next to the ovary. And so if you Google ovarian cancer, you will often see pictures of and read about a type called high-grade serous cancer, which is the most common and deadly type of cancer that people had traditionally attributed to the ovary. In most cases, it comes from that end of the fallopian tube. So that then brings us to, why are people talking about the fallopian tube so much? Because now that we really understand that most types of ovarian cancer, most cases of ovarian cancer are starting in the tube instead of the ovary, explains why in medicine we've never been able to develop a screening test, because many of our screening tests have relied on imaging like ultrasound, but there really is no imaging in medicine that can routinely see a fallopian tube, which is shocking to most people. I mean, it was sort of shocking to me, and I'm a doctor, right? And this has been an area of interest of mine for many, many years. And when you really sit down and think about it, the fact that we actually don't have imaging for a critical structure in the body, like the fallopian tube, is surprising.
So what do we do about that?
I think this is the question of the day, right? Which is, if we can't screen for ovarian cancer, right, with imaging or blood tests, and it's a cancer that we don't have a reliable way to eradicate, meaning we can't cure it in many cases, it's very dangerous, then is there something that we could do to prevent it? When you think about the option for prevention being ovarian removal, well, that's not so great, because the ovaries are an important endocrine organ, probably well past menopause, and this is a real active area of research. So, the idea that we could prevent a cancer by removing the ovaries is not so exciting. But knowing that to prevent ovarian cancer, or many cases of ovarian cancer, in a way that doesn't involve removing the ovaries, but rather the fallopian tube, which in medicine doesn't have any known form or function once a person has completed family planning, well, that's actually a more interesting idea, because the fallopian tube doesn't make any hormones like the ovary, and its job in life is to help with pregnancy. And so if either someone, doesn't want pregnancy, or they're never planning on pregnancy, then removal of the fallopian tube can be a very good option for prevention of this type of cancer that has a misnomer now, right? We've called it ovarian cancer when in fact it is largely fallopian tube cancer. And, the next most common question people ask is well, how successful is this, right? How good is this as a preventive strategy? And so I tell people, well, when you think about the most common and deadly type of ovarian cancer, this type called high-grade serous, fallopian tube removal right now, based upon existing data, is projected to prevent about 80% of those cases, which is just amazing. And when you think about ovarian cancer in general, remember I told you not all cancers come from the fallopian tube. Some still primarily come from the ovary. If you were to look at what fraction of ovarian cancer in general does fallopian tube removal prevent, it's probably on the order of maybe 50 to 65%. So still the majority, which is very impressive. And it's a procedure that is, generally speaking, can be done as a standalone outpatient surgery. It could be done in lieu of a tubal ligation, right? Which is probably the most common time in a person's life when they might be considering a salpingectomy, fallopian tube removal, if you're thinking about getting your tubes tied. Or it can be a procedure that is done at the same time as another procedure. And that's often called opportunistic, meaning taking the opportunity to offer somebody preventative surgery for ovarian cancer. So it could be done at hysterectomy, or people are starting to think about what are the other scenarios when it could be done. And lots of people have surgery on their abdomen in their, we say, post-reproductive years. So they have hernia repairs, maybe their gallbladder out, or other procedures, when if they knew this was an option, they might know they could ask their surgeon about the chance.
So this is not commonly known, though.
Tell me about why we don't know much about this. And also, you make it sound super easy, and I imagine that it's not as easy as you've just made it sound.
It's not so hard, but, I think there are lots of considerations, and we could talk briefly about those. I think the first question is that why don't people know about this? And a lot of people, they're kind of, what's the word, shocked and surprised that they don't know about this because it seems like such an important discovery, and it is, in health. Really, this has been something that has been embraced in the field of OBGYN, particularly when thinking about taking the opportunity to reduce risk at the time of like a hysterectomy. But beyond that, people have not really committed to creating, knowledge mobilization around this for whatever reason. I mean, primarily, we're not good at this in medicine, right? We're not good at conveying complex things or telling people about new scientific discovery. It's just something that medicine has not done well, unfortunately. And there are some barriers to implementing this in the field of OBGYN and then into surgical practice more broadly. In the field of OBGYN, I had mentioned one of the most common times that a person might consider a salpingectomy would be at the time of permanent contraception, right? So tubal ligation. There are some structural barriers to being able to have access to or to choose a salpingectomy instead of a tubal ligation. One of them, being like, for instance, in our state and in a number of other states, there's outdated health policy. And there's also not a insurance infrastructure that is fail-safe to guarantee coverage. And that's something that, we are really working on a lot of advocacy to address. And then in terms of translating this into surgical practice more broadly, that has a lot of important considerations. One being that it shouldn't be something that a woman, we think, or a person hears about for the first time, when they are needing to have their gallbladder out, right? This is really something that someone should hear about, during their engagement in their health throughout their lifetime. And that really hasn't happened right now. I think people are thinking, okay, well, if a person needs XYZ procedure, they could, like, they're coming into the doctor for it, or, God forbid, they're in the emergency room, whatever, they could receive counseling about this at that time, but it's not the most ideal time for something like that to happen. And it's better if people have heard about this throughout their health journey and they're prepared. So the idea being like, oh, well, I might consider having a tubal ligation, for instance, and I think I might prefer a salpingectomy instead. Or if I need a hysterectomy, I know to talk to my doctor about this. Or I know that if I end up in my post-reproductive years needing surgery for something, that I would like to also have this. So it's sort of something that the patient plans, and they're empowered to plan and choose. And the other reason is that there haven't been a lot of education materials created about this in OBGYN, let alone materials that could be used by doctors that are non-OBGYN doctors who are not familiar with counseling people about reproductive anatomy and physiology and, alternatives even, right? I think that the alternatives part of it is also really important because there are options besides surgery to decrease the risk of ovarian cancer. For instance, we've known for a long time that when people take birth control pills, particularly for a prolonged period of time or for at least 5 years in their life, that decreases the risk of ovarian cancer as well, probably upwards of 40 to 50%.
So if somebody were to have, for example, an ovarian cancer gene, this could really be a solution that is less damaging than, say, removing the ovaries.
Yeah, so I think what you're asking is if you have had genetic testing due to typically a family history, right, where there are a number of people who have been affected by breast cancer, ovarian cancer, sometimes pancreatic cancer, or colon cancer. What about the option of removing the fallopian tube instead of the ovary, for instance? And I think that's a really good question. That's something that is being studied right now. And as you pointed out, the standard of care for people who have a high risk of developing ovarian cancer in their lifetime due to a gene mutation, for instance, and these people, have upwards of a 40% chance of developing ovarian cancer by age 80. The standard of care has been removal of the ovaries. And really, the fallopian tube was just along for the ride, right? When this started in the early 2000s, people would remove the ovary. The fallopian tube would be removed as well, because there's no point in keeping the fallopian tube if you're taking the ovaries out and they share a blood supply. And people would look at the ovary and they couldn't never find any evidence that ovarian cancer started there until people started looking at the fallopian tube. And so really from this emerged the idea of, maybe we were going about it all wrong, and we actually need to focus on fallopian tube removal instead of ovarian removal. But we don't know for sure yet. And we know that risk-reducing surgery, as it has been done since early 2000, which means removal of the tube and the ovary on both sides, is highly effective at preventing ovarian cancer. Anywhere between near 100% to somewhat less than that, depending upon what's found in the fallopian tube at the time of risk-reducing surgery. But we don't know how effective it is to just have the fallopian tube out and to keep the ovary, or to do what's called a stage surgery, where you have the fallopian tubes out as soon as you've completed family planning, and you wait to have the ovaries out until you're closer to the natural age of menopause.
What is your aim here?
So my aim was I'm a person who takes care of a lot of patients and families who are affected by this disease and who suffer from this disease and die from it. And it has really been one of the most important areas of clinical medicine for me throughout my life. And I've dedicated, countless hours and love and devotion to it. And sitting honestly with my patients, many patients who are suffering from this or who are at the end of life from their life, I have promised them that I would continue to work on developing opportunities to prevent the disease, truly like in their honor. And that is literally what motivates me. And, it's gotten to the point, Stephanie, where I honestly couldn't sleep anymore, knowing that, so many people in the United States have an opportunity to know about this and to choose it, right? Because people actually choose tubal ligation more than any other method of family planning in the United States. Lots of people have hysterectomies and other surgeries where, if they knew about this, they could have the opportunity to prevent the disease. That people didn't know about this, that this was so siloed in the field of OBGYN, I couldn't sleep anymore about it. And so I just decided I was just going to work on it and for the rest of my life until I got as far as I could.
So you're out here spreading the word. Rebecca Stone, thank you so much for your time.
Of course. Thank you so much for having me and for really caring about this.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.